Hi. Good. All right. Hi, everybody. I'm Dr. Shadi Arabic. I'm a board certified spine surgeon and the Chief Medical Officer and owner of Vet Triage, which is a telehealth platform. I want to thank PRN. They are the ones that are sponsoring this and supplied all this awesome stuff for us to play with today. So please visit their booth. They're phenomenal and a huge advocate for our profession, improving all things surgical and other things as well. So a little bit about me. I graduated from Cornell University in 2006. Did my one-year general internship at Angel in Boston. From there, I did my surgical training at Long Island veterinary specialist. Moved out west to Las Vegas, where I practiced there for a bit, and then moved on to Silicon Valley, where I managed 3 hospitals and on call 24/7 for the year. And then after that, Los Angeles, California, for True Care for Pets. I was part owner and managed oncology, internal medicine, and surgery. And again, on call 24/7 for that year and a half, and then launched Vet Triage. This is the outline for today. We're going to go through a bunch of stuff. I'll have a couple of disclaimers right off the bat. First, I have to say this statement. As a courtesy to faculty and fellow attendees, please kindly turn off or mute cell phones, avoid any flash photography or strobing lights, and turn off any novelty blinking lights. But more specifically for this suture lab, a couple points to make. Number one, this is meant for folks who either have never touched any surgical instruments or have dabbled a bit, or maybe you're a bit more advanced and you kind of want to tweak some things, improve some aspects of your surgical habits, bad habits especially want to break. So that's kind of the goal here. Everybody here has a wide variety of experiences, and some of you may be doing surgery longer than I have. So feel free, it's an open floor. We're here to share ideas, and I would love your perspectives on different aspects of surgery. And so don't be shy. Help each other out as well. There are some suture knots in here that I frankly just don't perform, but I have them in here because folks want to use them. So feel free to help each other as well. How many folks in here are veterinarians? Okay. And veterinary technicians? No. Anybody else? Practice manager, receptionist, assistant? Okay, that's students. Okay, cool, good. So we'll see how it goes. This is our outline. Start with some thank yous, some reminders with basic kind of surgical principles, and then we'll dive into some academia regarding suture types and suture characteristics, and then we'll go through a whole bunch of knots and patterns from there. We're going to get a bit more complex as our lab goes on here. And again, thanks to PRN. Please visit their booth. They've been very, very kind with all the stuff that we have here. And then Dr. Miller, almost all the videos in here were made by him. The slides, I just modified my own flair to it, but Dr. Miller contributed all this. So for the past year and a half, we've been giving these suture labs, and so massive thank you to Doc. Okay, so we're gonna start off really basic with how to hold a needle holder. Now, we are set up for right-handed folks. If you are left-handed, my apologies, you'll have to modify things to sort of fit the drill. But this is what you're looking at when you're talking about an appropriate grip for needle holders. There's 2 ways of doing it, and this is the more common way, and maybe towards the small animal side, where you are placing our thumb in the one ring, the ring finger in the other, and then your pointer finger and middle finger are used to stabilize the instrument. What you don't want to have is a lot of tension in your grip. That type of fatigue will wear on you. If you're talking about a 1, 2 hour, maybe 3 hour surgery or multiple surgeries in a day, if you aren't having a lot of tension in your grip, it's going to cause fatigue, and you don't want a fatigued surgeon. You want to be precise and relaxed while you're doing this. So this grip, as you're going through the exercises today, keep in mind, try to focus on how much pressure you're putting in your hands. It matters. It'll add up over time. The other method besides the standard, what I call the standard way of holding this instrument, is also palming it. Some folks will palm it and they'll open and close the needle holders. It's more of a large animal thing. I've done it on occasion in small animals as well, but in case you read about palming the instrument, that's what we're talking about, but we're focusing on this. Lastly, some of your needle holders, maybe even all of them, have a scissor attached. Some folks hate the scissor. I love the scissor attached to it. But for those who hate it, we do have separate suture scissors at your table as well that you can also use to cut suture. Finally, these clamps here, if you notice when you tighten down, there's 3 levels of clamping, and you're going to decide based on the situation how tight you really need to clamp down on things. So this is sort of through time and experience, you're going to know how much grip you need. The same principles goes with the thumb forceps. These are brown accent thumb forceps. You all have one at your station. And again, a relaxed grip, relaxed but precise. So holding it like a pencil, there are other ways to hold it, but this is what we're going to focus on, is holding like a pencil, having the back end nestled in your palm, and you just want relaxed. Keep in mind the tension that you are putting on these instruments. Surgery is not about power. Well, let's talk about power equipment. But as far as your hands go, you want it to be finesse, relaxed, finesse, and controlled. And then there's some other things that we forget about. You know, this posture, right? If you are tall and you're trying to reach your patient, you're now bending over. Well, again, maybe for the moment you feel fine doing that, but talk about multiple surgeries in a row, that's going to fatigue you. So figure out a way to make yourself comfortable. If you had surgery yourself, you want your surgery to be comfortable and not be stressed or fatigued. So raise the table. Or if you're still too tall, spread the legs and sink down a bit. Whatever you can do to meet at the level where you can have your hands, your elbows nice and relaxed, and you're not doing this neck thing all the time, you're not arching your back, you can just go in. And if you're shorter, they have ways to elevate. You can have stools, you can elevate yourself up. Even the flooring matters, what kind of shoes you wear. All these things we forget about when you're in the middle of surgery, because it's exciting and you're trying to save a life, but at the same time you're compromising your own physical well-being. It'll add up. It's going to create fatigue. That fatigue resonates. Back of the skull, the neck, the upper back, right? These are things you have to focus on when you're doing surgery. And if you're in a long surgery or stressful surgery, we forget. So nice and loosey-goosey, controlled, but loosey-goosey, not a lot of pressure. It's going to add up. And we want you to be in the profession for decades and decades, right? You want to love this job. So that's some tidbits regarding surgery in general, as far as posturing and how to handle instruments. Now, before we get into all this other stuff here, at your station you'll notice you have a manila envelope. You can open those up. Those are your fleshy prosthetics. Those are our patients. They've got several different types of incisions on them. And so we're going to suture those incisions as we go through this. You should also have needle holders, thumb forceps, suture scissors, and then the tourniquet with the red and white rope. That's for vascular surgery that will go towards the end for those who are interested in how to tie pedicles off. But the main thing we're going to focus on for the beginning of this is going to be the suture, the prosthetic, needle holders, and thumb forceps. Okay? There are sharps in the middle of your desk. Some sharp containers are a bit ghetto, so please excuse the appearance. But don't get hurt, right? And that's where the sharps go. And then there's more suture in the middle of the table if you run out. I do have 2.0 and 3.0. I have, I think, maybe 0 and 4.0 if you want. These prosthetics are not like real patients, so the 0 and 4.0 might be a bit tough, but let me know if you need anything. Okay, suture types. We try to categorize them with different parameters. Some of your decision making with what suture you pick depends on what tissue you're working with. Mucosa, subcutaneous tissue, and skin. You want the suture to last at least days, right, in order to give time for the patient to heal. Fascia doesn't heal as well, so you want your suture to last weeks. Tendon, months. Degradation profile. How fast does that suture degrade over time, if at all? And those factors are the factors that are involved in deciding the degradation profile include what's the suture made of, what's the pH, what part of the body, what species you're dealing with, how much tension there is. All these factors come into play when you're trying to figure out what suture you want to use. That matters. And so some sutures absorb, those are absorbable sutures, and some don't absorb, non-absorbable sutures. The structure of the suture is what dictates the properties. Monofilament versus multifilament are another way of characterizing these. Monofilament sutures, which is what you have at the table, you'll notice they're very smooth. They don't have a lot of memory to them. They're almost too smooth for prosthetics, but for a real patient that has blood and plasma and serum, you'll have more drag. But regardless, monofilament, less tissue drag, which means less likely to snag as you're using them, less likely to harbor bacteria, less likely to cut friable tissue, whereas multifilament, which I don't use, some folks do use them in certain situations, and then maybe personal preference, or some parts of the body is better, but multifilament, easier handling, better knot security. It is more likely to harbor bacteria because all the crevices in those filaments, fluid, organic debris, bacteria love to live in there, and so there's that risk as well as potentially maybe causing more inflammation to the patient, but it's much stronger and easier handling. So you pick basically these factors. What tissue are you trying to heal? What's the degradation profile of that suture? What's the structure of it? And then the size. Bigger is not always better when it comes to suture. The bigger the suture you're using, the more trauma you have, because it's a bigger needle and a bigger diameter of that suture, and also that patient has to dissolve or deal with that foreign material. So the bigger it is, the more inflammatory reaction you're going to see, right? But also, you don't want to be too wimpy either. If you're using a very tiny suture in a large dog for like their skin or something like that, it's just not going to hold. Yes, less trauma and inflammation, but it's not going to be strong enough to hold that tissue. So you have to balance the amount of foreign material and size of the material you're using with the body part and the species in the scenario. And you learn that over time. You can make some pretty general guidelines / rules, but over time you figure out what you want. There are some that are pretty set. Absorbable suture can be considered short-term, like mucosal surgery or skin surgery, and here's some examples. Midterm, you're looking at some tougher tissues and also viscera, so you want them to last a bit longer, and here's some examples there. Then long-term, of course, you're adding in cardiovascular surgery, organs again, and then a bit longer. So you can see here, barely 2 months, maybe 3 months, and then you've got like 6 months. So that's kind of where we categorize the absorbable sutures. Non-absorbable, theoretically, they're in there for life. Okay, time for some action, finally. So square knot. This is the basics. So this is where we have to start, the foundation to do the rest of the lab. All of our patterns and knots are going to start the same way. I'm going to have a slide that's going to throw a bunch of verbiage at you, which will be almost useless, but I'm doing it to be thorough. Then we'll show a picture and then the video. Okay, and then during the video, we'll start practicing our patterns. The square knot is the most frequently used knot when placing ligatures and sutures. It is the most secure knot and least likely to unravel. Not great areas of tension. I'm going to define that here in a minute. The square knot consists of 2 simple throws, with the second simple throw in the reverse direction of the first. Both throws must begin with the needle driver between both strands of suture. Key points: think of both sides of the circle, stay in the circle. This will become more evident during the video. If it helps, just watch the short end of the suture, go in side to side, start on one side, go to the other, back and forth. We'll show it in the video. Tension, I'm going to elaborate on in a few more slides, but this is the square knot. Here's what you're aiming for. So I call it like a pretzel shape. This is what your goal is. This is how you know you're heading in the right direction with a square knot. Here are 2 square knots in a row. You're almost always placing more than 1 knot with your pattern, typically 3 to 5, depending on the suture, what part of the body, what species, etc. These are all facts you have to consider, but we're going to be doing a lot of these. So this is just 2 square knots in a row. If it was a real patient, maybe 3 to 5 in a row is what you're going to perform. And then here's the video. So for those of you who know what a square knot is, feel free to go ahead and practice it. Otherwise, I'll play the video several times for folks. This is Dr. Miller showing us how to perform a square knot. And you can start practicing it on your prosthetics. Have at it. Whether you want to use 2.0 or 3.0 sutures, up to you. Just whatever you like. If you don't like one, try the other. And so here he's showing the circle that we were talking about before, staying in the circle. This is foundational to everything we do today. You want to get this down before we move on. So this is very, very important for folks who've never sutured before, who've never touched an instrument before. This is imperative that we master. So it's a repetition of making a circle, staying in it, making a circle, staying in it. I'll play it a few more times and I'll walk around and see how you guys are doing with this pattern. Creating that circle, and we're staying in that circle. That's the goal here, stay in the circle. And then when you tie your first knot, you're creating the same circle again in opposite directions. And then back and forth, 3 to 5 times. Square knots. Theoretically, you can use this knot for everything. It can be small intestine, urinary bladder, abdominal wall, skin. This is the main foundational suture knot that we have to know. Play it again. I'll walk around and see how you guys are doing. For those of you who find this very easy, bear with us. But this is vital for us to learn. Okay. Yes, question. Is that a needle holder?
Yeah, needle holder. So I just can't get it.
Yeah. some of the needle holders are very, very new. You worked on. Found another one. See how this does for you. Here as well, or for you? This is it. Okay. I have a bunch here, so. Is that any better? Better? So the question is, does it matter if you have your knot right over the incision, or should be kind of to the side? I've never paid attention to that, or was taught that. I can imagine if you did focus on it, maybe it is better for the patient, because I would imagine friction is the problem, right? But I'm not sure I would focus on that, yeah. There are plenty of suture patterns we're going to go through too, that will, just by nature of what they are, be on the side anyway, but yeah, for these straightforward knots, I wouldn't pay attention to that. Yeah, that's the next slide. Yes, next slide will be surgeon's knot. Yep. Yes, so you'll notice that with these, because you have a monofilament, very smooth suture combined with a prosthetic that's not a real patient, you might find that your knots are getting kind of loose every time you tie them. That shouldn't happen in the real patient. So it's just, it's just the nature of what we're doing. Because even a surgeon's knot, which will be the next slide, it may not fix it much. It'll be better, but it won't be optimal. Yeah, you don't think it's you. It's me. Are we good to move to the next one? Okay, so here's a point that I want to make. This is one of those sort of bad habit things that I like to point out. In the picture here, the drawing, if you notice, Dr. Miller did the same thing. He placed the needle on one side of the incision and went straight across to the other side and exited. And if you notice, of course, the needles are semicircular, they're curved, right? So what you're trying to do here is you're basically forcing a semicircle structure into a straight path, which is not meant to be. Doesn't really matter in most cases, however, if you're working with very small instruments, a very delicate tissue, that forcing could result in bending or breaking the needle, and you're also kind of exerting more tension on the tissue you're working with. So I would argue that maybe a better way of doing this, and so you can get in the habit of doing this here today, is instead when you enter the first part of the incision, exit fully with the needle, and then re-enter the opposite side and fully exit. So instead of going straight across, like we did in that video and what's shown in the picture, exit first completely, and then re-enter the opposite side. And I would argue if you can do that, better technique, less trauma to the tissues, and you won't risk bending or breaking the needle. So keep that in mind too as we go through this. You see a lot of doctors are forcing it straight through with a really large incision, and you're fatiguing yourself, causing more trauma, and risking ruining the needle. So I'll point that out again in the next video with the surgeon's knot. So a surgeon's knot, also known as a friction knot. A surgeon's knot is often used in high tension tissues that cannot be properly opposed using a square knot. The surgeon's knot differs from the square knot due to an extra pass through the loop of the first throw. Double overhand knot followed by a single overhand knot. This extra twist in the first throw provides more friction to maintain position until the second throw is placed. I almost always use a surgeon's knot first, and then I follow up with a bunch of square knots. That's my preference. I know soft tissue surgeons will go more on the side of using square knots exclusively, in most cases, or whatever it is. My preference is surgeons throw first, and then square. This is what you're aiming for. The surgeon's throw is just, it's like providing two square knots, right? So you're getting kind of a double pretzel shape. And then after that, this is a square knot, like we just learned. You can do a bunch of square knots. So again, if you're aiming for 3 to 5 knots overall, I'm doing the surgeon's throw and then a bunch of square knots. So that's the surgeon's throw, and that was the comment about the friction part of this was if I threw a surgeon's knot, would that help? And yes, it's a friction knot. It's going to help with helping the knot be a bit stronger. So here's Dr. Miller. Again, now keep in mind, again, he's going to be pushing the heel straight through, which I would say is fine. With experience especially, you kind of know when to do that, but I would argue if you can exit out once you first enter and then enter back into the opposite side, that's better off for your own fatigue, for the tissue trauma, for that patient, and minimize risking the breaking or bending. See how he did 2 circles with the surgeon's throw. 2 circles, and then tighten, and then now single for the square knot. Play it again a couple more times and walk around and see how you guys do it. That's the surgeon's throw. And again, I'm pretty much always using it. The times I'm not using it, I'm worried about like the thickness of the knot. Maybe I want like a smaller knot, or maybe I'm just afraid of the extra inflammation from the absorption of the absorbable material. Or maybe I just don't need it. Maybe the tissue is just so delicate or what have you that I just don't need it. But usually I'm using a surgeon's throw, and then I follow up with square knots. So again, enter from one side to the other, across the incision, and then 2 throws in the circle. Boom and boom, and then grab the tag, and then come through. And after that, follow up, secure that surgeon's throw with a bunch of square knots. And folks do a lot of surgery, of course, it's very basic, but we have to get through the fundamentals so everybody's on the same page. Feel free, any questions, comments, throw them out there. Keep on learning. Nice. With these prosthetics, if you're wondering like how tight do I go, for these specifically, if you start seeing the incision sort of disappear, it's coming together nicely, that's what you're looking for. In a real patient, how tight do you go depends on what part of the body you're working on, how delicate the tissue is. So there is such thing as going too tight. You don't want to crush tissue, but at the same time you don't want to be so wimpy that the enterotomy you perform is going to leak, right? So there's that line there of feel. There are some techniques, of course, you can use to determine how tight you need to go and make sure you're not going too tight or too loose, but in general, it's going to be based on experience over time. Are we good to move on? Simple interrupted. So this is our first suture pattern, and a lot of folks here have already done this inadvertently on your prosthetics. You've already done a simple interrupted pattern. This maintains tissue position and strength if one portion fails. Minimal holding power against stress, but it requires more time, more suture. So this is doing a bunch of what you just did in a row to close an incision, right? How far apart you put them depends on the tissue you're working with. And maybe times you're just constantly adjusting and readjusting. Maybe you're like, oh, okay, this gap's too big, let me throw another one in there and then see how I feel about it, right? So it depends on what you're trying to do. But a lot of you have already done simple interrupted today inadvertently. This is the simple interrupted pattern. It is very good for folks who are starting out but are ready to like dive into maybe like an enterotomy or intestinal resection anastomosis. This is the way you do it. Or let's say we're not going to abdominal surgery, you're closing a linea alba and you're just not confident yet. You want to make sure this allows for more security. It does take more time, it is slower, and it does require more suture to do it, but what matters is what the patient needs, that's care, and so this is a very nice way of diving into surgery reliably, consistently, without feeling like you're getting ahead of yourself. So the simple interrupted pattern is dependable, easy. So we'll just go through the video and then probably we'll just move on to the next one. And again, you can go surgeons and then square knot, or you can go a bunch of square knots, depends on what you're wanting to do. The doc's just going to repeat it or not. Perfect. Any questions about that pattern? You've all pretty much done it. Okay. Cruciate pattern. Now we can get exciting here. So 2 simple interrupted sutures placed parallel to each other and tied across the incision, creating an X. That's where the name cruciate comes from. It's appositional, which we're going to talk about, and good for low moderate tension. We're going to tackle this now. Security is similar to simple interrupted sutures, but it's faster. It certainly is. And doc likes to use it for a cat body wall. So let's talk about these terms first. So tension. So tension is an enemy of reconstructive surgery. You don't want excessive tension on the tissues. That doesn't, whether it's intestine, urinary bladder, skin, subcu, you don't want a lot of tension. And so sometimes you're fighting tension because the body part that you're working on, or maybe the type of surgery you had to perform on that pet. And also you can create tension, which you don't really want to do either. You want tissues to be nicely closed together without feeling as though that the sutures are really struggling to keep that tissue together. Otherwise, what ends up happening is you can end up with suture pull-through or suture breakage, or the tissues, the blood supply can be compromised, and now you're risking seroma formation, dehiscence, infection, abscess, all the sequela. So you want a normal amount of tension, and if you look at surgery books, there actually are pictures of dogs, drawings where they have tension lines, because whether you perform your incision vertical or horizontal, it depends on the tension that's naturally for that body when you talk about skin. So there actually are tension lines. Your goal here is to minimize tension. Sometimes it's out of your control, and you need suture patterns and surgical techniques to help accommodate that tension, and the cruciate pattern is one method. It's a very strong suture pattern, which you'll hopefully appreciate on your prosthetics. So that's the tension discussion there. And then appositional, there's 3 types of ways of getting tissue together. Appositional is typically what you want. You want opposing tissues. One incision, one edge of the wound matches the other, and they're nice and snug. They're facing each other, right? That's apposition. So these patterns are typically appositional patterns. There are inverting patterns, which we'll talk about later. Those are when the tissue edges invert. So for example, if we're talking about like uterus or stomach or urinary bladder, we want inversion. We want inversion to help with that seal. So that's on purpose. Those are inverting patterns. Everting is the opposite. It's poking out. Most of the time you're trying to avoid eversion. Sometimes you want eversion, but usually you're trying to avoid it. And so typically eversion is just the nature of what tissue you're working with or bad surgical technique or what have you. But eversion is the other option where it's pointing outwards. So those are the 3 types, and most of what we're talking about is going to be appositional. It's kind of what you're going for in most cases, except for like stomach, uterus, urinary bladder, where you're looking for inversion. Okay, cruciate. This is what you're ending up with. So you're taking a bite, going across the incision, turning around, taking a bite parallel to your first bite, going through, and then tying it, and you end up with that X. That's what you're trying to do. Go through, come back, go through, tie it. Here's the video. This is my favorite tension relieving suture pattern, is cruciate. I love cruciate. I use it for really large abdominal wall surgery, so you've got like a Rottweiler GDV that you just finished, and you're trying to get this dog off the table quickly, either simple continuous, which we'll do here in a minute, or a cruciate pattern. These are really, really fast and very strong patterns. Or we're doing like a lymph node biopsy, and I just need one suture to close up, the lymph node's kind of bleeding, so those are always going to be bleeding. One cruciate pattern takes care of it, and now you've got your lymph node biopsy, and one suture took care of the closure, for example. Or if you're doing like dermal punch biopsies, this is great for punch biopsies of the skin. played a few times here, but that's the goal here. You're creating an X, and then either a surgeon's throw or a square knot. Chances are, because you're using the cruciate pattern for a tension area, you're probably going to use a surgeon's throw for the first one, because you're worried about tension, right? That's the idea here. So you probably won't use a square knot when you're talking about a cruciate pattern. And hopefully when you're doing this in your prosthetics, you can feel the strength, the difference in strength. That pull should be fairly obvious when you're doing a cruciate. Yes?
Just really quick habit. Why would you still recommend weight coming out and going in again?
Yes. Yeah, the question is, do you still recommend entering that incision with the needle, exiting fully, and then re-entering the opposite side? Yes, I do. I do, yeah. And again, that's if you're being picky about it, that's the way I think you should do it. There are plenty of cases you're dealing with a closure on a cat abdominal wall, so tiny, you just go straight through, right? You have to use common sense. If you're dealing with a patient who's critical, want them off the table quickly, get through it as fast as you can. You know, you have to sacrifice the ideal, what I consider ideal technique to get the patient off the table and safe and sound. Let me play this again. How many folks here have performed the cruciate pattern before? Yeah, okay, good, yeah, good. Yep. So if you're experienced with cruciate patterns, and something to look out for here today would be, what's your spacing? Are you doing pretty good spacing on both sides? Are you pretty equal? Are you really parallel, or are you slanting? It may not matter clinically, practically, but you're trying to go for perfect as you can. You want to make sure everything's nice, even and symmetric when you're doing this. And then there's different thoughts on how tight you go with the cruciate pattern. Some people think, well, there's going to be swelling post-operatively, so you should tie this kind of loose because it's going to swell and it's going to become more snug underneath it. Other folks are like, no, it doesn't matter. And I'm kind of on a case-by-case basis. If there's already inflammation and swelling, what have you, I'm going to go probably a little bit on the loose side. But that swelling will eventually subside and have to be even more loose. Or if I have a patient that I expect to have a lot of swelling, maybe idiopathic or systemic inflammation, maybe I'll go a bit loose on it. Yes? Yeah? Now you got credits, right? Yep. How many surfaces do we have? There you go. Yeah, you went in a loop instead of outside, that's all. Then the subsequent ones, you just go real light and script. Yeah. Now the fork interlocking is going to do what you just did, where you go in the loop. We'll talk about that in a minute, but yeah, so that's what happens. Play one more time for folks to catch up, and then we are going to the next one. horizontal mattress. The horizontal mattress pattern starts by creating a simple interrupted pattern, but instead of tying the suture, the needle is inserted some millimeters laterally on the same side as the needle exited. It crosses to the other side of the incision to exit the same number of millimeters lateral to the first side of entry in the skin. I'll show you the picture in the video. The suture ends, which should both be on the same side of the incision, are then knotted, good for areas of tension, useful in skin, may cause eversion. If not applied correctly, could cause microvascular disruption as well. And you can prevent that by using bolster with stents, buttons, or tubing. So we'll show you here, this is what you're trying to end up with. So now, you go across the incision, turn the needle around, and then come back the other side. And you are entering the other side here parallel to where you first entered. It's also all equidistant, all the same distances. Then when you tie your knot, now the knot is off the incision, it's on the side. This is horizontal mattress. What you should feel in this tension relieving suture pattern, which is appositional, hopefully you don't get the eversion, is this part of the knot. You should feel it kind of sink in and create like a dimple in your prosthetic. And that's the strength that you're looking for with this suture knot. You should feel it pulling the tissue to the other side. Because remember, using this for tension. That's what this is being used for tension. So here's what Doc is doing. Start on one side, go to the other, and again, ideally you would exit and re-enter. And then turn the needle around and go the opposite way. So parallel to where you first started, some millimeters away, but you're entering the same distance that you started with and exiting the same distance that you started with. And again, when you tie this down, you should feel the side opposite the knot kind of sink in like a dimple and be like sucked in. That's what you want. You want that tension. You want the suture knot to pull the incision towards the knot. And that's what creates the tension, the strength that you want for that area of the body that you're concerned with. And this is really, you're really using this for skin. I have used this for like joint capsule for patella luxations, for example, to keep the patella in the trochlear groove. This is fantastic for that. Nice, strong tension pattern. It's phenomenal for that. And the fascial blood supply is not as delicate as other tissues, so you're not worried about microvascular disruption necessarily. The reason why we worry about microvascular disruption with this, because if you imagine the blood vessels entering the incision perpendicular, and you're literally creating a suture closure that's parallel to that incision, you're kind of severing those blood vessels. Now, luckily, there's a lot of collateral circulation in the skin, so it's not really a big deal, and you're only using this in select areas of your closure. It's not going to be the entire closure, it's for areas of tension. So it's not that big of a deal, but and I've never used stents with the suture pattern, but I know a lot of folks have. So that can also help relieve some of the pressure from this. But in general, I haven't seen it been a problem, but you're only using it sparingly for areas of concern. So that's where you theoretically sever the blood vessels with this part of the suture. There you go. And then, of course, you're probably going to use a surgeon's throw because it's a tension relieving suture pattern, or knot rather, right? So it's probably going to do a surgeon's throw and then square knots after that, 3 to 5, depending. I'll play it one more and then I'll walk around and see how you guys do. Yeah. So the question is, how besides using stents, how else can we save the vasculature on this? You also can use it sparingly, so just use it like intermittently whenever you need it. And then also, yeah, if you have a smaller distance that you're traversing here, of course you're going to incorporate less blood vessels with that, and so less likely blood. You're going to probably need more of these though to make up for that. But yeah, those are 2 ways. And again, I haven't really seen it. And typically, if I'm outside of using it for patella surgery, I typically use this in the skin if I have an incision that's failed. You know, so the example I like to give is like some large breed dog, obese, you did an incision over the sternum, they're always lying on the floor at home, they're putting pressure on it, and it dehisces. And there's just so much tension there. And if I have no other option, I have to reconstruct it again, I'm probably placing something like this. Maybe cruciates, maybe a horizontal mattress, So I typically am using this in the skin for like revision surgery. I'm not necessarily doing it sort of preemptively, except for like the joint capsule of the stifle.
What about for like mass removals on distal limbs where there's not a lot of?
Say it again?
Like mass removals on limbs where there's not a lot of tissue input?
Yeah.
Would be appropriate?
Yeah, so limbs that have a mass that you're removing, you place it on there, sure. I worry a little bit about the circulation in that area, but yeah, if you need it, you can use it one to kind of get the job done, and then the rest of your closure is routine, sure, yeah. It depends, because you see a lot of like mast cell tumors, for example, it's already gnarly and, and distal limb, and yeah, it could be necessary, but also it's kind of like a rock and a hard place with that.
So what about developing the bad habit of always repositioning your needle with your fingers?
Yeah, so what about the bad habit of always repositioning the needle with your fingers? You want your instruments to be an extension of your fingers. That's what you want. And so theoretically, if you're doing this appropriately, your fingers, albeit they're covered in sterile glove, maybe even your double glove, depending on the surgery, they should be touching the patient. That's the ideal. So, for example, if you see where Doc, let me start with this. I think I figured out how to use video. So, there's sometimes parts of the surgery where like you want to put your hand on the patient to stabilize the incision. So right there, for example, right there, where Doc's got his oh damn. Okay, I know. I got that. Hang on. This is a good example of what you're saying. Oh my Lord. So stupid. Press the pause button. Okay. So you see how we put this finger there, right? That's pretty natural for us. Instead, take your thumb forceps, close the tip, and use that to put pressure on the skin to stabilize that patient for you, right? Thumb forceps instead. Or if you notice when he was at the beginning picking up the skin edge with your thumb forceps. I'm really messing this up. You'll see folks who, and we all do this, you take your thumb forceps to pinch on the edge of the skin, so you pick it up and then insert your needle. If you can instead, use your needle to pick up the skin for you. It takes some work to do that, but you can literally guide the needle through the edge of the skin and have it exit where you want it to without having to put the thumb forceps on the skin, which is going to cause more trauma. And as your question about the needle, you would like to grab the needle with your thumb forceps and not your fingers. You have to get the habit of having your instruments be an extension of your hands. See Doc's using his hands there, you kind of, you want to avoid touching stuff. The reason for that is because there's bacteria on the skin, even though we've sterilized the area, and that bacteria loves to enter tissue, especially tissue that's been traumatized, so you want to minimize that contact.
So ideally, you don't want to use the forceps to pick up the edge.
Yeah, you can avoid. Yeah, if you can avoid picking up the skin edge with the thumb forceps and instead try to use the needles to sort of guide your way through, that's better for the patient, trying to minimize trauma. I'll show again and then cover the next one. He probably does it with the thumb forceps part. But yeah, but it's tricky. It's very annoying in the beginning. It's very annoying to do that way. So a lot of us just give up on it. But if you're looking to kind of clean up what you've been doing with surgery, it's a good practice. Vertical mattress. So the vertical mattress pattern involves entering the needle some millimeters from the incision line on one side, exiting the other side of the incision at the same distance. Needle then turned around and entered halfway. So notice halfway from the incision line and exited halfway from the incision on the opposite side. You then tie it. It's a tension suture pattern. Stronger than horizontal mattress, less tendency for eversion, but of course you have still the concern for microvascular disruption. This is what you're looking for here. So you enter one side, exit, turn the needle around, but now instead of entering parallel, you're entering in front of where you exited. So halfway between where the incision is and where you exited, that's where you're entering. And then when you go through the opposite side, this picture is badly drawn, but you are entering in front of where you entered, or you're exiting rather in front of where you entered. That's what you're trying to do here. So when you do this one on your prosthetic, leave a lot of room. Take a bigger bite. Take a big bite out here, go across, big exit, turn it around, and you've got plenty of room to go in between where you exited, and the same idea on the other side. You're gonna go in between where you entered and where you're exiting. Show it here in the video. The doctor's using his finger again. Instead, use a thumb forceps and close the tip, and then you can kind of push on the skin and let the needle, see how he's doing that? And let the needle guide where you want to go, and then you're going to exit the incision, then re-enter it, like I was saying, same idea. You use your thumb forceps to put pressure on the skin to maintain some stability, and then use the needle to exit and enter again, as opposed to lifting up the skin with the thumb forceps. And then for this pattern, you see how he's entering in the same line? He's in one straight line here, right in front of. And then exiting, same thing, right in front of. See that? And so you see now you're getting a vertical instead of a horizontal. I'll do it again. And again, the knot will be on the side. You're probably going to use a surgeon's throw, and you should feel the tension. You should feel the tension where it dimples, which is the idea here. You want that tension. You want to be pulling the tissue towards you. I don't use this that much, honestly. I'm using more the horizontal, but anyway, you may find yourself in a situation where you might need this. Playing it again. So again, just for good technique, use the point of the needle to guide you through the tissue instead of lifting it up with the thumb forceps if you can, and then stabilizing the patient instead of using your finger. Use the thumb forceps, close it, and push down the nose of the thumb forceps. Let the needle guide you, and then exit, enter. Much easier on a real patient, than these prosthetics. You're trying to stabilize the whole prosthetic and all that. Well, there's some logistical difficulties here today, but that's okay. The idea here is to get you comfortable with, or at least give you exposure to these patterns. Then maybe you can work on a cadaver first if you're really new to surgery and try all these techniques. I will have this video uploaded on my YouTube channel if you want to watch it after today. My channel will be at the end of the last slide. I'll show you if you guys want to subscribe. You can, or not, and just watch the videos. It's okay. When we're done, I'll play one more time, and I'll walk around. Hopefully you guys are appreciating the tension that it's bringing to this. And if you want to really feel the tension, really tighten down that suture for the prosthetics. You should feel it sink in. And then again, it's a tension relieving. This is for areas of high tension. That's what you're using this pattern for.
So what kind of procedure would you, or what kind of incision would you use?
Yeah. So what kind of incision would you use this pattern for? I don't really use it, but if I was going to, it would be the same obese dog that's dehisced. And I'm like, what the hell? I have to reoperate. It's probably that. And it probably depends on the orientation and how much real estate I have to do the revision surgery. But again, I'm probably going to go either for a cruise kit or a horizontal mattress myself, and maybe not use this one as much. But anybody here have experience with this pattern? Does anybody use it for a specific? What do you use it for?
Like really big mass removals that I'm trying to close. I'll start at the end of the incision just to get some tension relief off and work my way to the middle. I find this works really well.
And you would use, for the large mass removal, you would use this at the ends of the incision?
Sometimes I start at the end if the middle is super wide.
Yeah.
If it's not super wide, then sometimes
Okay, yeah. And so I imagine then maybe using a few at the beginning, the end, maybe a couple in the middle, and then the rest are going to be whatever pattern you want. Yeah, there you go. Yeah. So it's for problematic skin closures where you anticipate a problem, or for me, if it's like a revision, then I'll probably use these. And it's going to be in combination with other techniques, right? You're going to undermine the tissue. Maybe you're using skin stretching. Maybe you're using tacking sutures or walking sutures. There's other things you can do in combination. This is not like it's going to solve all your problems with these cases, but it's nice to have an arsenal of options that you can utilize for these. And then from there, it's trial and error, experience, just learning, you know, because I hate the answer of, I just never used it. Why? I don't know, I just didn't, I just never did, you know. And it's nice to try and play with these things and see what you can get out of them. See what you like, what you don't like. But we are creatures of habit, we tend to stay with the same thing, and that's, you know, not great. Any other comments, questions, anything? Moving along. Killing it. Well, saving lives. Can you feel the tension when you do these mattress patterns? You appreciate the pulling in? Yeah, you'll notice the prosthetics has to lift up on one edge because of all the tension in the closures. So it's good. Are there any objections to moving forward? All right, let's do it. Okay, so continuous. Our first continuous pattern. Simple continuous. So out of all of the fundamentals, you know, the square knot is your fundamental, and then for continuous patterns, simple continuous is your fundamental. This will take care of most of what you need, as long as you're not getting too exotic of surgery or too complex. This you need to know. Starts with a square knot, one diagonal pass, one perpendicular pass. If needle advances above and below the skin, you get a running suture, which is not as good. Minimal tension holding with good apposition. So not very strong, but we'll get you the apposition that you like. And then a good seal, pretty fluid and airtight. But if it breaks, the whole thing is going to fall apart. So if one part fails, the whole thing will fall apart, whereas it's simple interrupted. If one fails, hopefully you have the other sutures that are intact to save your incision, your closure. So you start off with the same pattern we've done, either a square knot with a bunch of squares, or a surgeon's throw with a bunch of squares, and then you, instead of ending it there, you now go across, take a bite, go across, take a bite, go across, and so we're going to show that here. And then the other part that you'll learn here too is how to end a continuous pattern as well. So we'll talk about that too. And again, for folks who this is pretty rudimentary, just to have good practice. Otherwise, for other folks who have not had this before, this is a fundamental to continuous patterns. So it takes a bite, goes across, and then either a surgeon's or a square to start off with. Common places for this are going to be like the linea alba, if you're doing like a stay or any other abdominal surgery. If you're confident with your enterotomies, you can do it for an enterotomy. If you're confident with intestinal resection anastomosis, you can use it for that. If you're closing urinary bladder, uterus, or stomach, you can use this for the first layer. So your first layer of the two-layer closure for those thick viscera will be an appositional pattern, like a simple continuous, before you follow that up with an inverting pattern. But this is quite versatile. You're closing the mesentery after intestinal RNA. I'm using simple continuous. So you keep on repeating this as it goes across, another bite. And again, you're trying to be cognizant of the spacing, try to make it all symmetric and even, so you don't get any slanting. And you stay outside the loop. See that? It stays outside the loop. See that? If you're getting stuck somewhere, the most common error that I see is folks are going inside the loop. So see this, he's taking his bite, come across, and then outside the loop. There you go. Outside the loop. That. And then as you come through in the prosthetics or a real patient, you can put some gentle tension, some pull on this side, so you can tighten up your closure. You don't want to end up all the way at the end and then you realize, oh, I didn't maintain tension the whole time, now everything here is loosey-goosey. You don't want that. So you intermittently will put tension on it, and in a real patient, the skin and the fluid will help keep it under tension, whereas with the prosthetics, you keep on loosening up on you. So it's annoying and not realistic, but the idea is to be aware of that. And then I'm gonna play this again with a special focus this next time around on how to end this, because you're gonna end up with a loop at the end that, if you're not familiar with this, might freak you out. We'll go through that.
Don't freak out.
So now when you cut it, you're gonna end up with 3 tags instead of the 2, because you created a loop at the end. Here you go. Play it again. Here. Kind of loose, but make sure it keeps here. And then I'll pause at the end, folks who want more help with the closure, how to end this pattern. Again, stay outside the loop, try to keep distances the same, try to minimize contact with skin with your fingers. Use the thumb forceps closed to push the tissue down so you can angle your needle better. Minimize pinching on the skin edge. That's what Doc's doing with these. He's not lifting up the skin edge with the thumb forceps and causing more trauma. He's putting pressure on one side with his finger, which should be a thumb forceps, and then using the needle to guide his way through to minimize contaminating it with the gloves. So now he's creating that loop there. So you see where he's entered, exited, entered, exit out here, right? So he's opposite to where he started. We started on this side, he's opposite, and you have that loop there. See if I mess this thing up. There we go. So now, so he's doing a surgeon's throw with that free strand, and then he's going to grab the loop and bring it through. Just like that. See that? What he did? So that's how you're going to end it. So pretend that loop is just a single strand. That's what you're trying to do here. So there's nothing really different about it, but that loop ends up creating some confusion sometimes if you're not used to this. And then tighten down, and then square knot, square knot, square knot. Again, pretending that loop is just a strand, which we've all done here today. And that's how you get the 3 tags at the end. That's how you end this. I'm going to replay another point that I want to make here regarding placing this pattern under tension. Okay, so let's do that again. That's the break time, which we can decide if we want to break or not in a minute here. Okay, so it creates that loop in the circle, surgeon's throw, comes through. Part right here. Okay, all right. So, a couple points of tension here. So, when you are pulling on this loop to start your closure here, there's 2 ways that you can make sure that the tension being placed in the loop is actually helping with tension for the rest of the closure. So, because you might have a really good closure here, nice and tight, and then you do this part, and it becomes kind of loose at the end, which may unravel the whole thing. So for this part, you want to do one of two things. You either keep the jaws open, so the jaws are open, while you're putting tension, while you're pulling on the loop, and of course you're putting opposite traction on this side, so you're putting traction on the tag, putting traction on the loop, but with the loop side, your needle holders are open. The open jaw will help hopefully symmetrically put tension on both sides. As opposed to closing the needle holder, now the tension's stuck there, you closed it. You leave it open, it'll seesaw its way to have symmetrical tension. The other part you can do instead is once you tie this part, before you move on, you can pull on each side of the loop independently while you're putting tension on the tag. So while you're putting tension on the tag, you pull on this side of the loop, okay? And then you pull on this side of the loop. And then you feel the rest of your incision get tighter. So it's a trick you can use for, again, it may not work that great with the prosthetics. The prosthetics just don't have the same texture, but that's something to consider when we're closing more continuous patterns today, is how to maintain tension on the loop side. So you can see what Doc does here. He has the jaws open for that reason. There are some other videos where you'll see him put tension on each strand of loop too. I typically am doing both. I've got the jaws open, and then as an added level security, I'm pulling on both sides of the loops to make sure. And all the while, you're putting tension on the tag side too. Any questions about this? Do we want to break or keep going? Keep going? Let's do it. Okay? Forward interlocking. This is what somebody was trying to do this accidentally before. It was a forward interlocking. So, modification of simple continuous pattern. Each passes through the tissue is partially locked. Linked to the previous passes through a braided loop of material. At the end, the needle is reversed. Knot is tied to the loop left in the suture material. Good apposition, good stability for breaks. Problem is, more suture used. Maybe hard to remove, although I've had other classes that have said, no, it's actually pretty easy to remove. So this is certainly, I think, still more of a large animal technique, but lots of small animal lots of small animal veterinarians do this as well. And I don't, but I do think it's underutilized in the small animal field. I think this is a very cool suture pattern. This is what we're ending up with. So it's just like simple continuous, but now you're going inside this circle as opposed to simple continuous where you were outside the circle, right? And that's what's going to create the locking mechanism you're going to see. You're going to feel the strength in this locking as you do it, even with the prosthetics. So it may look more complex, but watch Doc do it here and see. We're starting off the same way, one side to the other. Surgeon's throw to begin with, and we've all done this already, and then square knots. So nothing new here. It's pretty much the same. We've been doing this. Yeah. Now, just like a simple continuous pattern. Come through. Now the difference is going to be you're going to stay in the loop. Staying in the loop now. See that? In the loop. In the loop. Boom. That creates that locking mechanism. And as you continuously do this, you'll feel it locked down. It's very cool how it does this. So it's a really nice pattern. It's got a lot of elements to it. Through the loop. And then we'll talk about the closure for this, or how to end it rather. And pull through, you should feel it locked. Or locked. Looks kind of like pi, 3.14, looks that, to me that's what it looks like, little pi symbols. And I don't know why he started in the middle of this video, I'm not sure there's a reason for it. Anyway, alright, in the circle. Walk, good. And turn the needle around, and it's going the opposite side, other direction. So you turn the needle around, opposite to where you started, goes across, and then forms that loop, loop. Then surgeon's throw, grab the loop, and close it, and again, either keep the jaws open to maintain tension on both sides of the loop, or you can look what he does. See this? Pull on one side of the loop, pull on the other side of the loop. See that? That's to help lock it into place. That's not specific to this, that's any time you're doing continuous pattern with the loop at the end, you can pull on both sides of the loop to help maintain tension. So that your entire knot can become loose because you did not end it well. Should be a shame. Play it again. How many folks here use this in practice? Yeah. Good number. Good. Okay, play it again. Forward interlock. Is the consensus typically that these are hard to remove at recheck, or maybe sometimes, maybe no?
I would use these in prolapses on cows because they only have to cut the top knot. If the cow is calving, they only have to cut one knot.
Oh, so the owner of the cow would do it.
Right. Rather than a U-trick where you gotta really shove that thing all the way up there,
Yeah.
the muscle of the honey. I just use it for interlock.
And they can just unravel the whole thing on their own? Yeah. And I just heard about I heard of the U-trick way back when, but I'm gonna incorporate the future ones, because that's come up now twice in this.
Or a buner needle, when we use a buner needle.
Buner needle.
All the way up and then all the way down.
Oh, okay, yeah. I vaguely
On the
remember that.
cow.
So that's,
On the
yeah,
cow.
on the cow. Yeah.
Then we use that forward interlock in, a lot of times on calf legs on horses.
Right, yeah. I think somebody else said yesterday for using goats or something, it's not a standing procedure, the goat's knocked out, they're doing whatever they're doing.
I use it on C-sections.
C-sections too,
On
yeah.
small men.
Yep.
Or small ruminants.
C-sections and small organs. Yeah.
They're more of a risk for damaging tissue if you've got two mobile planes against each other and that sort of thing.
So is there more of a risk for damaging tissue if you've got two mobile planes happening here? I don't think so. Has anybody ever seen like vascular damage, tissue damage from this type of? Yeah, no, I haven't seen either. I'm wondering, because you're right. So one of the problems that you have with suture pull through is you get this like sawing effect sometimes, right? And that ends up creating a larger defect where the suture entered and exited, and also it's literally sawing the tissue, and the tissue is very friable, like small intestine, on like a ferret or a cat or something. You can saw through it. So you don't want that kind of mobility. Hopefully with this pattern specifically, it's locking, so hopefully you don't have enough mobility. But yeah, it is a problem that I typically see with, typically you're picking either the wrong suture size, like you went too small, or you have too much tension, or the area of the body should have been immobilized and you didn't immobilize it. So there's usually factors that you could have done to prevent that if it happens. But you can tell if that happens, because you're seeing the suture pull through. So it would be indicative on the patient when it comes back to like a dehiscence or something like that maybe that seesaw thing happened, that sawing motion happened. So it forms a loop and then closure. Anybody want to stay on this slide longer? Yep, okay, no problem. And then you again, he pulls on both sides of the loop to maintain that tension. Don't forget when you do that, you're also putting tension on the tag. Because if you don't, you're gonna end up messing up your whole closure. You have to redo the end part again. So you want opposite tension on the tag side as well as the loop side. There you go. A couple other questions we typically get in these courses is where do you place your needle holders on the actual needle, on the actual curve of the needle? Because you can place it anywhere you want, right? So if you're too close to the base of the needle, so that's where the thread is attached to the needle, and you don't have a lot of control in general, you're going to find that your needle is swaying back and forth, and you're also putting a lot more pressure on the pointy part of the needle. If you're too close to the pointy part, you're not going to have a lot of room to actually penetrate that tissue, and you, again, have even less control because the needle is very thin compared to the base. So you want to be somewhere halfway between the base and the middle of the needle, somewhere in that realm where you're aiming for to have a good combination of control over it, but also not stressing out the metal of the needle. So somewhere between halfway between the base and the center of the curved needle, that's where you want to hold it. So it may be intuitive to a lot of folks anyway, but you can see where Doc's holding this thing. You want to be somewhere between base and halfway through. He's very close to the base. It does depend on the size of the needle and also what tissue, how tough is that tissue you're going through. Oh, yes. Yeah.
Right.
You're trying to end it? Or is this, you're trying to go further? Yeah. So that's like, I think you go through the loop here. Then you skip that step. Then you try going through the loop afterwards. So here, so pull this out. Let's try it again and see if I can do this. Try it again. Now you take it right here, that one insert. Then you might have to loop and then try going back around and just did like that. Yeah. Yes. Yeah. Yeah, yeah, yeah. This part, you take this right here, you go on this side. That is it. One of the, yeah, I think maybe we lost tension now. It looks fine. It's fine. Yeah, I think just, yeah, we just lost tension. I think that's probably what it was. Yeah, because they probably should have, yeah, I think it looks fine, yeah. Yeah, okay. Initially I thought you went backward, I was like, well, that's the problem, but no, yeah, I think we just lost tension.
Okay.
We lost on this side, right? There we go. Oh, okay, I see. Yeah, I think we lost. Yeah.
Okay.
Yes. Wow. Yeah. So. Yeah. So for folks who use sport interlocking, other than skin, where else do you use it in the body? Do you do it subcutaneous? No. Skin. Only skin. Only skin. Yeah. I imagine with subcutaneous, you probably end up tearing the subcutaneous tissue, is my guess. And it's probably overkill, because the subcutaneous tissue tends to really react to inflammation with suture in general, so you kind of want to minimize how much suture material you put. Like, for example, for cast abdominal walls, I never close subcutaneous. They flare up, and they'll end up ruining the entire incision because of all that inflammation with steatitis. So, but it's probably overkill for subcutaneous. But yeah, it seems like only skin. I've only learned about it with skin. Should we move on to the next slide? Okay, inverting pattern. So now we're diving into visceral surgery. So maybe you'll use this, maybe you won't, but I want you to have exposure to different suture patterns. These are inverting patterns. So there are two types of inverting patterns. We're typically using these for abdominal organs that have two-layer closures, the stomach, uterus, urinary bladder. The first layer will be your simple continuous appositional layer, which we've already done. The second layer in these organs will be an inverting pattern. There's Cushing, which goes split thickness, and there's Connell, which goes full thickness. So if you look here, as this person is taking bites, they're taking bites parallel to the incision, going the opposite side, parallel, and the needle is only entering mid-thickness for those tissue layers. They're not entering the lumen. So this would be like the inside of the stomach here, for example. They're not going all the way through, they're split thickness. So regular surgeon's throw with some square knots, and then parallel, come over, parallel, come over, parallel, come over, parallel, come over. The Connell is the same exact thing, except now the needle is going through. See how it's entering the lumen of the stomach in this example? So same pattern, but Connell is going in. And so the way I think about it is L for lumen. That's how I remember them. So Connell goes in the lumen, Cushing is mid-thickness. For our purposes here, these are really hard to try, but we can do it here. But you're not worried about split thickness versus full, because these prosthetics are not made for that. So you're just going to do inverting patterns. I want you to see what it looks like. I just made this video today before you guys came in, so it's kind of ghetto and rough. I didn't have a good video before this to show this. So this is me doing it. So pretend you've already closed the first layer of the stomach with a simple continuous pattern, and now we're closing the second layer with an inverting pattern. So we're going to start off the same way we did a simple continuous pattern. Just take a bite on one end, exit through, take a bite on the other end. Almost lost the tag there. Surgeon's throw, come down on it. Square knot. So again, your focus is, I just want you to get the feel of an inverting pattern, just so you know what it's like. But don't worry about split thickness and full thickness, but we all know now, technically there is a difference. So now we're going parallel to the incision. See that? So I went the opposite way, parallel to the incision. Other side of the incision, parallel. You're trying to create like a zipper type of pattern here with this. And then you should start seeing it sink in. So you're going to start seeing the tissues dimple inwards. They're going to invert. They're going to pull inwards. So just just kind of a cool one even if you're not gonna do visceral surgery, at least you kind of get a feel for this and see what it feels like. If you ever do get into this, then you at least have tried. So, and you can see how as we continue to pull through the inverting pattern, see how the tissue kind of sinks in? That's what you're looking to achieve here with this. So kind of a fun one to try. I'm not using this anywhere else other than abdominal organs that are two-layer closures. So this is not something that you're commonly using unless you're diving into abdominal surgery. That's the inverting pattern. Yeah. Yes?
Is there any benefit to doing this with both layers of your closure?
Is there any benefit to do this with both layers of your closure?
So you can do that again.
What's that? You know, my answer is going to be no, but I'm open to discussion. So the simple continuous pattern is such a good, tight, appositional pattern, which is what you want for that first layer. The idea here with let me play this again. The idea here with abdominal organs is you're trying to prevent abdominal adhesions from forming. And so any exposure of the mucosa to the abdominal cavity is going to risk that. That's why we do this, because we want to make sure that we don't have that problem. But I don't think you'd want to do an inverting pattern. I'm trying to think, I had a cat many years ago that had such a screwed up bladder. It was borderline like necrotic, right? So you could barely close the thing. I think it was for a urinary obstruction for a bladder stone. And I only closed it in one layer because I had no option. And I can't remember if I did inverting or appositional. I might have done appositional only because there's not enough room. With inverting, you need some tissue to pull in. When you do it, you know, so I think I probably did a simple continuous pattern, but yeah, I don't think so. Anybody have a different idea on using two inverting layer closures? Yes.
When I was in school, which was a long time ago, like 2003 is when I graduated, so you were taught two-layer inverting suture on the bladder.
So she was taught in 2003 after graduating vet school, two-layer closure inverting for urinary bladder. Do you know if they ever did it for like stomach or uterus, or was it kind of only a urinary bladder thing?
I think it was just bladder.
Yeah, so interesting, man. Anyone else that did that before? Yeah.
I've done it on stomach.
Yeah.
Because I felt like it had a nicer closure, but then I don't know if it's contraindicated or.
Yeah, I mean, you know how it is. At the end of the day, the pet did well and great, but as far as like what's like seen as the ideal, yeah, I haven't, but yeah. I can't think of any other good medical reason to not do it. And I hate the reason of, well, we're just taught that way. It's such a bullshit answer.
Okay,
You know?
it's fine.
Yeah, so yeah, well, there you go. You apparently can, yeah.
Do you want your bite on the right pretty parallel with the bite on the left, or do you want to like stair step down?
Yeah, so the question is, do you want this to be opposite each other, or you want it to kind of be step down? I'm aiming for opposite here, even though I'm doing a very bad job of that. I recognize it, but yeah, I want them to be I want you to go stop. Okay, parallel to the incision, come across, parallel, come across, parallel, come across. But sometimes you'll notice here, I'll go parallel, then I come across like this, like diagonally, and then come across and go kind of like off a little bit. So the beauty about being sloppy like this, let's say, is that these organs are very forgiving. And so as long as you're getting that inverting feel to it, it's fine. But I'd like to do more of like a stepwise or a cross type of thing, as opposed to slanting, constantly being different. Yeah. But yeah, I'm here. I'm just rushing it. But in actual surgery, these organs are very forgiving, and as long as you're getting a nice inverting pattern to it, then it's okay. And also a lot of times, almost always, I'm doing an omental patch on these two, depending on how concerned I am. But for all my cystotomies, I'm taking omentum and I'm pulling it down, as long as it reaches, and then I'm tapping into the urinary bladder. For uterus, no, I'm not. But I almost never do, C-sections where I'm not staying them, so that's my experience with that. And then for the stomach, if I'm really worried about the patient's metabolic stability, hemodynamic stability, the stomach looks kind of weird, kind of questionable, I'll pull up some momentum and tack it on the stomach as well.
Glad to hear somebody else say that.
Yeah, you do that as well, momental tacking?
No, well, I do mental tacking, but saying that you almost never do a C-section.
Oh.
That's why you don't.
The C-section, yeah. I imagine there are lots of veterinarians who do, and they have a strong clientele of breeders or what have you that do it. So, but yeah, for me, it's typically a
Not me. It ain't happening again. At 2 o'clock in the morning, I'm gonna get happening in the morning.
Any questions about this one? Yeah. Yeah.
So I primarily would be doing like skin sutures, but they
Yeah, so the question is, and I look at other people's opinions on it too, because I don't do a lot of dental work myself, but is there any advice for closing extraction sites? Like for the gingiva, for example, like what pattern would you use? Any kind of like helpful? Horizontal? So horizontal mattress? Horizontal mattress is a good one. Simple interrupted, that's just what I do, simple interrupted. And if I need more tissue, I do kind of like a flap, undermine it, and so I can bring things over to close it. But yeah, simple interrupted, horizontal mattress, cruciate. What's that? Oh, okay, so cruciate is separated by a couple simple interrupted. What needle size do you guys use for dental? It depends on the patient, sure. 4050? 4? Yeah. Paper needle, 40.
When you're doing omental patches, are you tacking that omentum on the incision, next to the incision, where are you putting those techniques?
So for the omental tacking part of it, where do you put those sutures? So let me go to, here we go, here's the stomach. So this is an inverting pattern. So if I'm gonna take an omentum and let's say I want to cover this incision, my goal is, first of all, to cover the whole incision if I can. So I'm taking the omentum, and I'm gonna tack it in at least 2 places, maybe 3, but at least 2 to keep it on there. So if you only tack it on 1, it's just gonna hinge. So place the omentum over this incision. I'll probably put 1 simple interrupted right here, 1 simple interrupted, right here, or whatever, on the back side of the stomach there, and that's what I'm aiming for. And then maybe for some reason, if I want more security, I can put a 3rd simple interrupted on the back side over here of it, and that's all I'm doing. The adhesions from there will take, theoretically, I don't know, I don't do a second look, but I presume that it's gonna attach itself on from there. That's all. So it's pulling with no tension, the omentum, putting on the stomach, 1 simple interrupted here, 1 here, 1 here. I'm probably using the 3O PDS that I use for the stomach closure, and so that's the extent of it. And that's gonna be the same idea whether you're talking about a pyometra pedicle, those ones thick like pyometra pedicles that just grow, and that's actually another uterine 2-layer closure sometimes. The pyometra is like a really thick stem, and there's like all that caseous material. I might do a 2-layer closure there, then omentum. But urinary bladder, same thing. And urinary bladder actually, because I have stay sutures in there, I had 1 neuroabdomen that leaked urine from the stay suture site. So stupidly annoying. Again, it was hard to diagnose it too. Like, what's happening? The bladder looks fine. So that omentum actually covers not just the incision, but also the stay suture sites too. Or I'll put like a cruciate in the stay suture site and then omentum over it. It's whatever you think you need. But it takes 1 case like that to be like, all right, fine. Omentum for everybody. Any questions about inverting pattern here? Kind of fun, kind of different. Okay. So this was the next slide was just saying for 2-layer closure, you start with something continuous and then go with inverting, but it just kind of sucks like in the video. And this is what you're ending up with. Okay, so before I move on to more complex things, I just want to recognize how far along you guys have come, especially for folks who've never even touched an instrument before or done any kind of surgery. So we've got square knot, surgeon's knot, simple interrupted, simple continuous, forward interlocking, tension relieving patterns. Thank you again to PRN for doing this. Please visit their booth. They're awesome. And then thanks Dr. Miller for supplying me the majority of these talks. And this is my information here before we move on to more suture patterns. If anybody wants to contact me for any reason, you can. I'll put this video on my YouTube channel. This is my company here, next to PRN again. So all that, folks who want it. And then let's move on to some other stuff. So this is kind of more, I would consider it more advanced, but maybe not for all of you or any of you, we'll see. But this here is showing the bury the knot. This is burying the knot. So if you want to dive into surgery, you're looking for more cosmetic closures for like the skin, for example, you like to learn to bury the knot. And there are different ways of doing this, but one way that I like to do is you start off by placing your first bite here deep, so this is considered deep, and then you come up towards the superficial, and then you re-enter superficial and exit deep, and then you tie your knot. Now, obviously with these prosthetics, you don't have a lot of depth. You have to kind of get a style, just get the feel of it. But I want you to be exposed to it. When you do it this way, deep, superficial to deep, and then place your knot, you're going to put tension on your knot parallel to the incision. Parallel to it, not across, parallel to it. And what's going to happen is if you do it that way, the knot should sink in or get buried by the skin. And that gives you a nice closure where the knot is now hidden. It's purely cosmetic. We'll talk about in the next slide what to do after that. But this is burying the knot. So I think one of the best incisions on your prosthetic to do this might be the curved ones, maybe. Yeah, maybe that S-shaped curve at the end of that might be a good one to try this on. It's got some depth to it. But it'd be cool to practice these. And if you haven't done it before for skin closures, if you do lots of spays or whatever, neuters, then it's a good one to practice, and it looks really nice once you get the hang of it. So that's burying the knot. I think the next slide I have a similar idea here. Okay, yeah, we'll talk about what to do next after that. But if everyone wants to kind of just bury the knot, go for it. And then you would proceed from there with a subcuticular closure. The subcuticular closure is between dermis and subcutaneous tissue, and the subcuticular closure adds to the cosmetics of our wound. It gives it a really nice appositional pattern to the closure. It's very, very nice. So once you bury the knot, oh, I forgot about this picture here. There you go. That's what this looks. Done. There it is. You can go in with a subcuticular, and the subcuticular pattern is kind of like a snake or another like zipper type pattern where you're taking bites like this. This is subcuticular, so between skin and subcu. Taking a bite parallel to the incision, like deep, and you're going back and forth like that. Taking bite after bite after bite after bite, you're getting this sort of this snake, slippery type of S-shaped zipper fashion for it, and then you can end this by burying the knot as well. And that's a really cool way. If you get used to this and get good at it, you can pretty much close the subcuticular layer and even the skin with just this pattern. Maybe need a little bit of skin glue, depending on on what kind of patient you're working on. A little bit of skin glue maybe, and that's the end of it. Or maybe it's not enough, and you have to close the skin separately, which is fine too, right? But for tinier patients, especially like cats or rabbits, ferrets, you can maybe get away with something like this. It's a very nice way of not avoiding any suture removal and making it a cosmetic closure. So it's a good one to practice on. And it'll be way easier in a real patient because these prosthetics aren't good at this. Let me see if I have a video. No, I have to make a video. I don't have a video for this. Yeah, sorry. I know. Let's do it. Put it up.
Okay.
Yeah.
So
Yep, so, and you're trying to exit past, you right there, you're trying to exit at this juncture. Yeah. Yeah. Before you get right. Yeah, before you get right there you go. Now, the other side is opposite way, and then you'll see. opposite direction. You're basically in reverse of what you just did. Official. Go ahead, yeah. You went deep. You did the table, you went deep. There you go. Yep, there you go. Good. Good. And then come out. Yeah, I mean, prosthetics are not made for this, but I want to be close to it. Yeah. Oh. Yeah, I mean, I wouldn't have done that. I would have appreciated the deeper layer, but I would have switched the skin also. Yeah. Especially for a big dog who's probably like rambunctious and. Yeah. Yeah, no, I'm okay with deep layer being appreciated or whatever he wants to do, but the skin should have had, I think, another decision. That skin there is thick. It's a male dog, so he's out of control. Okay. Yeah, no, no. No, for dog leaders, typically, I'm almost always doing a 2-layer closure, and it may be just a cruciate and then, another cruciate, or a cruciate, like a mini, like a particular pattern, right? But, yeah, no, that's all right. You don't even feel bad. Yeah, it's nothing. It would have saved a bunch of time and all that stuff. Yeah, yeah. The biggest issue I see with skin glue is putting too much of it. Just a little bit, but I also always use e-collars. No matter how tiny an incision, people always want to surgeon, so I'm very proactive about that. Yeah, but no, I would have done a 2-layer closure for that one. Or you can just like go a deeper layer and just close the skin, but. There you go. There. Oh, yeah. Yeah, this is very valuable. Very cool. The other thing I'll say about dog neuters actually is we had a question here about a dog neuter that it's a large breed dog, maybe a year or 2 of age. They did a cruciate closure for the subcutaneous tissue and just some skin glue for the skin and a DHS. And so the question is, should she have done something differently? But yeah, I would have added another closure for the skin, maybe in particular or cruciate or what have you. But I do see as a surgeon a lot of old intact male dogs, like 6, 7, 8, whatever large breed. They have these pendulous scrotum, and they get neutered. And next thing you know, massive scrotal hematoma, all this ulcerative dermatitis in the scrotum. It's a mess. So what I typically try to advocate for in these really large breed geriatric dogs that need neuters is a scrotal ablation. So when I see them as a surgeon, they have these like really disgusting whatever complications from a routine neuter, you have pre-scrotal castration, scrotal ablation. Take the whole stack off. It's a bigger surgery. There's a lot more involved with that, but it takes care of the problems and no scrotum left.
Have you tried a scrotal tack on those guys?
No, I have not. The question is, have you tried a scrotal tack? No, but I've heard of it. But no, I've not.
Yeah.
Does that work for you?
On my older big dogs, and they do great.
What can you describe it just in brief? The scrotal tack.
You basically take a hemostat, stick it down into the scrotum, grab some tissue, incorporate it into your subcutaneous layer, and grab it from the other side, and incorporate it into your subcutaneous layer, and then I just do a subcutaneous.
Almost like a scrotal lift, like you're
Yeah.
pulling that tissue from the scrotal sac up and incorporating it into your pre-scrotal incision.
Yes. Yeah.
There's a lot of
Yeah.
so much.
Lots of What was that?
I use a laser, so I don't do free scrubble, I do just the scrubble.
Yeah.
I do incision, I take the surgical out of the
The CO2 laser. Yeah, so she uses CO2 laser. Yeah, and then you glue it. Yeah. I've been learning more and more about the CO2 laser. He was talking about it yesterday with Briggs Phallic surgery. I didn't know you could use it for more than Briggs Phallic, and yeah, that's great. That's great. Yeah, good. Wonderful. Let me charge my computer here. Okay, tacking suture. So tacking suture, tacking the subcutaneous layer to the deep fascial plane is useful for decreasing or eliminating dead space. Dead space is when there is space between tissue layers, and what ends up happening is the body's natural response to dead space is to fill that space up. And it fills it up with serum or plasma or blood, and if that area gets infected, then you're dealing with not only a seroma, but now potentially an abscess. And so sometimes there's an indication to tack the incision. And so I'm going to show this video here. So this is similar to what we just did with a bury the knot, right? The doctor is going from deep to superficial, and then superficial to deep. This is of course subcutaneous tissue, or fascia rather, or subcuticular, whatever. And then they're tacking it. So before they make their knot to bury it, they're taking another bite in the wound itself, which then brings the two edges closer together and eliminates the dead space. And then the surgeons throw parallel to the incision for burying the knot, parallel to the incision, and then a bunch of square knots. I'll play it again. This is very useful for your standard like abdominal incisions, let's say large breed dog, lot of dead space there, or you're dealing with like a massive mass, in the lateral thorax or the sternum, and you're trying to bring tissue together, and there's some tension there, or maybe you're worried about dead space, which is what the point of this is. So you'll take a bite, deep superficial deep, and then take another bite in the wound itself before you tie the knot. And this is tacking. You're not using this in every single part of that incision. I've had surgeons do that, and these dogs are very uncomfortable with that. You need some mobility of the skin. So it's like tacking, and then a bunch of regular closures, and tacking, and a bunch of regular closures, whatever you need. Depends on the area that you're dealing with. Maybe you need one of these, maybe you need several, but don't tack the entire incision. That's not the goal here. The goal is just to intermittently tack where you feel that there may be a problem with dead space. Again, because prosthetics here are not made for this, you can try and practice it here, but these incisions are made for it, but I want you to be aware of techniques like this to help with these closures.
If you tack at an incision that big, but there's lots of dead space, if you tack at the beginning of this one that big, would you do it at the end too, or would that cause too much tension?
The question, would you have the tacking, you can tack it like in the beginning, and then tack it at the end, would that be okay, or would it be too much tension? Actually, honestly, what I'm typically tacking for is usually the center of the incision, because if you have like a standard elliptical incision, let's say you remove the mask, that's really where I'm using these. The ends are not too bad typically, depending on the body, but that midsection where you're trying to, so now you're undermining tissue and trying to bring it together using needle holders or sharp towel clamps to stretch the tissue a little bit, tacking intermittently. So usually I'm using these in the center of the wound and not the beginning or the end. Yeah. Any questions about this one? That'll be kind of a cool one to just give you some exposure. Another similar one along the same vein, I don't have a video of this one, walking sutures. So similar idea is where you have that elliptical incision, the center part is giving you trouble, a lot of dead space, too much tension. You can undermine the tissue here to get some more, but then you still want to bring this over. And so what you can do is you can take a bite in the deeper section here of the tissue, and then when you exit it and you got your next bite, you're taking this bite cranial or in front of this one. And what that does, once you close it, at that knot, it's going to bring those layers closer to center. And so this will allow, this tension here will allow you to relieve tension up here. That's the idea. So similar to tacking, but it's a bit more aggressive. You're taking a bite in the deeper tissues, take another bite on the wound bed, but cranial in front of, and then tying in. Those are walking sutures. And so this takes advantage of like mechanical creep to try and stretch things, or if we were to place towel clamps across here and give it a few minutes, 5-10 minutes, with intention, you'll find the skin actually stretches over those minutes. And I do that with radical mastectomies, for example, right? So while I'm closing one side of the radical mastectomy, the other part of the incision has a bunch of sharp towel clamps that are pulling on the tissues, providing tension. And so when I get there, I get a lot more elasticity. And so these are long incisions, long surgeries, so you have the opportunity to just work on one side while you're stretching the other side. So anyway, these are tension relieving techniques you can use to not put too much tension on your closures. How many folks have done the Aberdeen knot before? Okay, yeah, okay. So we're gonna show you this. This you can try. I have 2 videos on this one. This one is to me a complex one that looks really easy. It apparently is very strong. I don't use it. Apparently it's very strong. But if you don't get the tension right, the whole thing's going to unravel for you. So they start off with like a simple continuous pattern, and then there's the Aberdeen knot. It's a hand tie, as you can see, and it's quick. It's really secure, but it requires some practice. This one. So play it again. There it is. That's the Aberdeen. And this you can practice with your prosthetics if you want to. Do a simple continuous pattern, and then when you're about to close it, this is the closure. This is the end point of it, and not your typical like creating a loop and what we've been doing. This is the Aberdeen. Oh, definitely, yeah.
So you don't use this for your gastroparesis?
No,
Okay.
no, you do use it for gastroparesis?
I do it for the one knot on the one side, and then when I don't have to cut it into the second side, I just
Continue it on. Yeah. So a lot of folks will use this as for continuation of 2 layers, typically, or 2. Yeah, two layers. So she says she uses it for incisional gastropexes. This is the one you want? Other way? Oh, okay. Yeah, I glossed over this one. It said this history.
Okay.
Yeah, I don't for gastropexes. I don't. Yeah, just a continuous pattern. I start with the cranial deep aspect first, and then the superficial. I'm doing 2 incisions parallel to each other for the gastropexy. Yeah, but I start with the deeper cranial one. That's where it's the hardest to have access to, and then I do the superficial one.
Is this just to save time, or?
Yeah. So for folks who use this, why do you use this knot? Secure.
I feel like it varies better.
It varies better.
It saves a lot of time.
Saves
Oh my
time.
gosh,
It's fast. I'm gonna play this slide. It's the same thing. It's gonna show the same one, but this is the burying a comment here. So in this video they're gonna smurf it, which you can do if you try to bury the knot at the end of your incision. It didn't really bury well. You can kind of get it buried by smurfing it. So first they're gonna do the Aberdeen. It's just another angle, another view of the Aberdeen knot. The 4th rows, and then come through, finish the knot, and then he's gonna smurf it. Smurfing it is you take a bite in the actual wound, and then come out somewhere, usually lateral-ish, and then as you pull through the tension, that knot will sink in. And maybe a little bit of skin glue if you need it for that. And then you just cut the tag flush to the skin. Play it again. So folks want to try this, have at it. The next couple of slides we have left, for those who are interested, will be vascular surgery. We have 2 more slides, millers and modified millers, and that's what the tubing structure you have there will be used for folks who want that. Otherwise, I do have a gift for you guys to take home with you. You get your own prosthetic practice suturing at home. So, yeah. All the other stuff is good, you can't keep. You keep these. Yeah. Enjoy. They're a little bit annoying. They are going to lift up on you, but you have to stabilize it at home.
Do you know where the origin of Smurf came from outside of the cartoon?
Not the cartoon, no, I don't know.
Alright, I know there's Dr. Smurf.
Oh, does anybody know the Smurfing come from somewhere in particular, that name, or besides the cartoon?
Or is it from the cartoon?
I always know the cartoon because it was underground, but, right, but I don't know. Or actually, these are an official name for it, but maybe it's not Smurfing. Take care of your patients, maybe the sensitive creatures. Anybody want more Aberdeen time, or should I move on to the next vascular surgery? Oh. How horrible. Did everybody get one? Good, yeah. Enjoy, courtesy of PRN. This is their booth. Anybody want more time with Aberdeen? Is anybody practicing that? All right. Here we go. So modified Miller. So for vascular surgery, so you have the tubing in front of you that you would pretend is the vessel. So the center part here is going to be the vessel. And then you have the red and then the white to give you an idea of keep yourself knowing where you are in space, and then use these to practice vascular. So this is modified Millers here. And again, as a surgeon, I'm a bit spoiled. I'm using ligature, so I don't, I'm not doing these, but what I hear from folks who do a lot of these is they prefer the modified Millers to the Millers. They feel a little bit stronger. I'm itching to do a medical literature search to see what studies are out there to compare the two in experimental settings and clinically, but anyway, for folks who are dabbling with vascular surgery or find yourself sometimes working in a deep abdominal cavity where your instruments aren't long enough, you don't have the luxury of like a thoracotomy pack like I'll usually have, then you're relying on hand ties. And so for vascular surgery where you're relying on a hand tie in deep abdominal cavity, this is a good one. So if you want to practice on cadavers, if you want to practice on space, this would be a fun one. If you want to dabble in like splenectomies or what have you, these are good ones to learn. So Dr. Miller is showing us here, you loop around the vessels twice, and then you come in the middle and tighten. Pretty straightforward. If I am doing ties like this with suture, then typically I'm doing a circumferential and a transfixation is kind of my go-to. Sorry, I don't know why I can't get it. But there's your modified Millers. So loop, and then parallel to it, another loop, cross, and then go in the middle of both loops, and close it. And if you are doing a double ligation for pedicle, and you feel like one is more secure than the other, you want to have the more secure one deep to the patient, like in the abdominal cavity. So if your less secure one slips, you have the deeper one to rely on. Of course, you want both to be really good, obviously. But yes.
So is that all you throw? You don't throw a square knot on top of it?
Yeah. So for folks who do this, do you stop here, or do you have to throw additional like square knots on top of it? More? Yep. Additional square knots. How many do you throw?
At least one.
At least one. You said 5?
I just throw.
Oh, you throw, yeah. 4? Yeah. 2. Well, I think they're counting this one. This is 1 knot we're saying, and then 4 more squares on top of this. Yeah, squares. It's for vascular surgery, right? So it's a blood vessel, so you're looking, you need security, you wanna make sure you have it, so that's on around the line. Yeah, whatever you need to get the job done. Yeah. Yeah. Like more time here, we have the Miller's next, but still working on this one. Then you put it in the bucket. Now you do yeah. Yeah, that's the thing, the bipolar ceiling device is,
I'd like a ligature, but.
yeah, for equipment like that, you wanna do you have to justify the cost of it, right? So, yeah. I mean, I've done ligatures on regular spades, on dog neuters, they all just find a reason. You know, if they're going to specialists for routine procedures, it's like, well, you know, yeah, so. But it makes most of these surgeries a joke. It's so easy here, you know. Yeah, oh yeah, I've done 9 to 10 minutes, flanectomies from open to close with, because ligatures, it's just so easy, you know. Spleens out, abdominal score, liver biopsy, close. You're out. Should I move on to the Millers? Okay, so Miller's not. So now instead of going parallel with the loop, you're going across the first loop. And then I'm gonna go slow here. And come out the first loop you created. So again, I hear folks like modify more, but this is the Millers for those who want to know. be stronger, but. Yes, as we continue here, give yourselves a round of applause for getting through all this stuff, learning all this new techniques. Good job. And if you have any questions, you want me to play any other videos, what have you? Otherwise, you're released whenever you want to go. Thank you so much. Enjoy the rest of the conference and safe travels too.
Thank you.
Yeah, yeah.
Do you want us to clean up our garbage?
No, we'll get everything. Thank you for offering, yeah. Yeah, we'll clean everything up. Yeah. Thank you.
Thank you.
You're welcome. Thank you, guys. Thank you. Good job. Good job. Hope you got some tidbits of information today. Anything else?
Throw all of this.
You can leave on the table. Yeah, thank you for offering.
Thank you.
Yeah, yeah. Thank you. I'll put this on the YouTube channel the next week or so. It'll be up there. And folks want to practice at home.